when we were putting this program together, we realized that, Americans may think, and certainly people working on the Medicare program may think that they know a lot about payment models, but oddly enough, many people in other countries get health care, and many physicians actually get paid for providing that health care. So we decided that having an international panel would be an interesting idea. And we had a very interesting one set up, as Bob explained, that I happened to be in Berlin this summer on vacation, and as people are apt to do, I had beers with our speaker that we had lined up, and we were all set, but more important events overtook, and we ended up having we're having a pinch hit panel, and we're very, very grateful to the three speakers. They responded very, very quickly to our call for an alternative approach. And let me introduce the three of them and get started. We're going to be hearing about Canada, France, and the United Kingdom. And our first speaker is Antoine Groux, who's the Deputy Director General of Health Services and Academic Medicine in the Quebec Ministry of Health and Health Services. And Antoine is a family physician. He's been practicing since 2004. Since 2016, he's acted as the Deputy General and has been very active in piloting primary care reform in the hope of improving Quebecers' access to timely and high-quality care. And something that Antoine doesn't know is that my mother's side of my family is from Canada, grew up in Montreal, so I'm very interested in making sure that people get primary care in Quebec. Our second speaker is Victor Rodwin, who's a professor of health policy and management at the Wagner School of Public Service at New York University. And Victor was a visiting professor at a conservatory in France. I'm not going to try to butcher these French names, but he is very familiar with the French healthcare system and will be talking about that. And our final speaker, Simeon Schwartz, a name I can more easily pronounce, is the CEO of Optum Practice Partners, a physician management services company, and he's based in London and has been responsible for Optum's initiatives in the UK, focusing on general practice development and new models of care. And he'll be telling us a lot about some of the innovative primary care systems in the UK that are working, that have been put in place and are working, and the extent to which they are working well. So we'll be hearing from all three, and we'll start with Antoine, who's got slides, and everyone else does not have slides.
So hello, everyone. Hope you'll apologize for the slides, but it does help with the language, so going to make it easier like that. Just a few things to show you a little bit of how things work in Canada. As you see, he's very healthy, and I don't know about his family, but things are not doing so bad at the end, for some people at least. As in Canada, as you know, there are things that are easy when we compare to the United States system. Some of the things are not, and some of the things are workable. This is mostly capturing the resource costs is certainly something that is easy in Canada. As you know, we have only one public health system. Well, 65% of the services in Canada are public, so one payer only. Well, actually 10 payers, or 12, because we have one system for every single province or territory in Canada. So that makes 12 out of it all. And the medical services are covered by more than 95% overall. So, and this single payer for physicians who are self-employed is also certainly making things a lot easier. The target incomes across specialties is something by opposite that is really not easy. Unions share their money on their own, so we have very little impact on making the money go within one specialty or the other. And achieve policy objectives well. This is the reason why we're here. Provincial payment schedules are definitely workable, and this is what we're doing. So just to give you an idea of the trends that are going on right now, I think this is very, very small for you. And even worse, the circles have moved during the travel. So you can imagine I didn't expect to show you what about the blank part. But anyways, so the idea was to show you how things went from 1999 up to now 2016. So you see in the blue line up there is fee-for-service, and it's going down. But since 2008, it has kind of stabilized. And as for APP, which is, this is also a language trick, in Canada we use APPs for APM, so just make them fit together. You can see that the APM has risen, but at some point has also get stabilized. So right now in Canada, and now the red circles are right. What I wanted to show you is that when you combine a blended system plus the fee-for-service, you get almost 84% of the remuneration in Canada that is offered in that way. And one very interesting thing as well that I did not circle is that incentives and premiums are scoring very high at 0% right now in Canada. So in terms of value-based remuneration, we couldn't say we're really ahead. Provinces' disparities, the proportion of total clinical payments, if you compare it, so FFEs, once again, fee-for-service in blue, and you get the orange part for APPs or APMs, you can see that it does vary from province to province and behind the gray part of the territories, but you get from 13 more or less to 48%. So it gives you an idea of where we're heading in terms of this kind of repartition. As for the physicians' disparities as well, the proportion receive APP payment really is also varying a lot from 16% to 93% at the top, depending on the province where you are working. The specialties also have shown very significant differences. If you consider on the very right the surgical specialties, where you see that fee-for-service, as it was said a little earlier, are still very high. On the counterpart, family physicians who are working more and more in patient medical home in Quebec and elsewhere in the provinces in Canada really are thinking a lot more about these blended systems of payment or APPs. So actually in Quebec, primary care especially is putting a lot of efforts into getting its policy objectives realized by including some of this blended system of fee-for-service plus something. So we are heading for population satisfaction, which is right now, and I understood this morning here that your issues are likely the same that we face. Better access really is ahead in the ideas of our population in Canada, and especially in Quebec, since we're very bad at it. And so what we offer right now is a sort of a blended system of remuneration in patient medical home, which we call in Quebec le groupe de médecine de famille. Their remuneration there is based on rostered patients plus an access rate. So it's not capitation as absolutely as it could be, but we're offering doctors, physicians, we're offering them a bundle of money depending on the number of rostered patients they have. And we do add something, and this is unique as far as we know, to Quebec, of an access rate, which is the yearly visits made by patients to family physician divided by the yearly visits made elsewhere in primary care settings. So that we're targeting an 80% of the visits for one patient to one family physician, which is really what we are right now establishing as the basic of this evolution of access. So we do link that idea of rostering patients that is definitely known and certainly not new with this new aspect, bringing great value so far. We've just been doing this for a couple of years now, and we have already seen for the very first time a lower number of visits in our emergency rooms in Quebec, which is really significant. Volume and access are both up. Doctors are working more hours and offering more advanced access and access overall. And patient satisfaction, as a recent survey said, really is also going up. But of course, in these kind of strong changes, provider satisfaction, doctors at front are definitely more mitigated. Hospital, I'll go quick because we are not doing as good in hospital. The policy objectives are pretty much the same, but remuneration is really more on, as you've seen, on fee-for-service. And what we've tried to do is include some per diem to get to blend system, but this per diem plus FFS without any control or any expectations or requirement gave a very poor value. We are seeing costs going up, volume and access are down, and patient satisfaction, we have no clue because it's not traditional to evaluate what patients think about what we're doing for them, especially in hospital treatment. So this is just beginning in Canada, outside hospitals and primary care. So bad experience. Orientations really are a little bit in the trend of what you said this morning. We're thinking about this APP, but trying to find a simple solution to a complex problem really rarely works well. And this is what we're realizing right now, just obviously as you are all realizing. But nevertheless, we're wishing to increase the access rate I was talking about to at least 85%, as a recent survey also indicates clearly that patient satisfaction by 85% access rate just rise like crazy. So we are expecting to get that target higher. And I'll stop right there if I want to keep up with this 10 minutes. There you go. Thank you.
Given the time constraints, given the time constraints, I know what to do. I will begin with my conclusion, and then proceed as far as I can get. First, the French experience suggests that it is possible to modernize and adapt an obsolete healthcare system and contain costs, if that was an objective, within the context of fee-for-service payment on the basis of a national fee schedule. I won't comment on how well it's possible to do that, because I don't know, based on anything I've heard this morning, how well it's possible to do that in any of the many systems I've heard about here. But it is possible to do that, and that's what they're doing. The second conclusion is that the role of the payer, the national health insurance system in France, has evolved, as payers have here, except that it's one for the whole country, has evolved from a passive reimburser, simply repaying services after they were delivered, to a much more active player in managing patients, patient care, information derived from claims data. And that's a very important transition. Now, context is everything. I remember the first chapter of the PPRC that was based on this. So I have to say something about the context of the French system. And I remember Bob Evans, in his inimitable language, once characterized the Canadian system as a bilateral monopoly due to the legislative exclusion of private health insurers from covering the basic package of services, and France is exactly the same. Not only is it a bilateral monopoly, which has legislative exclusion of private insurers from covering anything covered under the basic plan, but also it has an institutionalized national structure of negotiating machinery between the medical profession and the national health insurance funds. Likewise, and that follows from what I've just said, in France, I have to emphasize there is no choice of insurer. Everybody's in the same boat. You can choose your complementary insurer, but not for the basic package. No choice of insurer. There may be minor differences according to occupational categories. There are many different funds. It's a multi-payer system, all following the same national rules. So in this respect, France is very different than what one often hears about Germany or Switzerland or Netherlands, where patients can choose among competing funds. In France, there is no such choice. Everybody has the same insurance for the basic package, but you have complete choice, as in Medicare, on where you get your care. So paradoxically, France has a much more pluralistic system than the image of a centralized state would lead one to believe, and more pluralistic, I would say, than Canada and Quebec. France is neither an example of socialized medicine like Cuba, obviously, or our Veterans Health Administration, nor is France a government-run system like the NHS in the UK. It's a national health insurance system which combines large elements of public finance with private provision, largely for ambulatory care, and now I get right to the topic. Care in the ambulatory care sector is dominated by fee-for-service paid doctors, who are paid according to a national fee schedule based on, believe it or not, 7,000 CPT codes. And the French do everything their own way. No American influence. There are no fee adjustments for differences in practice costs across geographic areas. 48%, almost half of all physicians in France work exclusively in private fee-for-service practice. 41% work in full-time salaried practice. The remainder work in some combination of both. The ones who work in salaried practice are largely working in hospitals, public hospitals. The ones who are working in private fee-for-service practice are largely solo-based or group-based, but groups of 2 or 3. That's the situation. Now, there's, unlike Medicare, which is, from the French point of view, a very government-run sort of system, there is extra billing. Physicians can be part of Sector 1 or Sector 2. If they're in Sector 2, they can charge whatever they like, as long as they charge it with tact and measure. That's never been carefully defined, but that's another topic. 11% of general practitioners are in Sector 2. 41% of specialists are in Sector 2. 79% of surgeons are in Sector 2. 56% of ophthalmologists are in Sector 2. And in Paris, Lyon, and Marseille, it goes up to 90% in Sector 2 among these specialties. Hip replacement, no, I won't even go in. So the physician fee schedule and its problems. Despite the significant differences between the US and France and the language barriers you evoked that have hindered cross-national understanding with respect to Medicare, France, no less than any other nation, has been strongly influenced by innovative administrative technologies born in the United States, because we're the country of innovation. Every panel this morning, every member of the panel talked about how innovative they were. And conceptually, I have no doubt about it. They were strongly influenced by DRGs and now reimburse all their hospitals on the basis of DRGs. They were strongly influenced by the work of Bill Schau and the Payment Review Commission, PPRC. And over the course of the 90s, they came up with their own RBRVS, Hiérarchisation du Travail Médical des Actes Techniques, CCAM, with 7,000 codes. Since 2002, when this schedule was put in place, there's been very little change and very little update, and that's the process. So I have 2 minutes, and I will summarize the key points. First, the update process, very complicated, as you can imagine, but it is done through a commission called the SHAP, with 16 members, partly from the National Health Insurance Fund and partly from the specialty societies. The trade unions nominate specialty society members, and they take a random selection and they fight it out. They do studies, but they're not as science-based as what Paul Ginsberg would have us want, or anything comparable to what we did here. There's much more of a concern about incomes policy and what's the right amount given the incomes policies. 2 key problems. First, nothing has been done since 2002 to update the scores of the CCAM procedure codes through the update process. And although they've agreed that they should reduce overvalued procedures and increase undervalued procedures, they have been far more successful, big surprise, in increasing undervalued procedures than in decreasing overvalued procedures. Second, practice costs have not been updated. This is the agenda for this coming year. And they will be updated, but there's a big discussion, as you can imagine, on whether it should be updated based on observed costs or based on what the costs should be if people modernized their practice and took advantage of everything we've heard about this morning. What works in France is the system of institutionalized agreement every 5 years, where they meet on a regular basis and hash this stuff out. And the final minute on recent developments and challenges in France is that they've tried to encourage the growth of health centers by paying lump sum fees to set them up all over the country. They've tried to encourage coordination functions by having lump sum payments for transitions out of the hospital and back to care, for maternity, back home. There are different programs here. They've tried to increase payments, and they have succeeded for chronically ill patients. So if you take care of an 80-year-old who's got all kinds of conditions, you get 80 euros on top of what you've got. There's a whole barometer of fees. They've tried to improve access to care for physicians in Sector 2. They've increased fees for complex consultations based on the profile of patients and their characteristics. And last and not least, they have had a P4P program influenced by their neighbors across the channel. But they've used it differently. They have 940 points with a whole series of measures and composite scores. The doctors don't know when they will be remunerated more or less. They find out at the end what they've done based on the information on them. And that's where they are today. So I come up with the conclusion that I came up in listening to this morning's meeting, which is that this is really a false dichotomy, what Bob Berenson has given us. It's not a question of one or the other. It's a question of both and they're doing both, and we need a lot more work. I'm working with Miriam Laugesen and Michael Gusmano at Columbia University on a study in Japan, Germany, and France, and we've just started doing interviews to see how they're going to manage to change that system and bring it into line with the demands of 21st century medicine while maintaining a fee schedule and using lump sum payments. I'm sorry to have gone over time for a few minutes.
Thank you. So now we are going to move across the channel and see what who the French have been learning from. And so the National Health Service, as I understand it, has been paying GPs based on capitation and doesn't really use a fee schedule the way France does. So I think it would be interesting to kind of get a sense as to how satisfied policymakers are with capitation, whether it leads to stinting of care or possibly specialty referrals. And then we'd like to hear about the UK's QOF, the Quality Outcomes Framework, that is a very, very large pay-for-performance initiative that has been mounted in the UK. So turn to Simeon for some insights on that.
Thank you. I think I can make two conclusions about this audience today. The first is, judging from my accent, you can probably guess I'm not native to London. The second is that you probably all have an opinion about the NHS, informed or not. And there are a lot of reasons for that. The NHS comes up in politics all the time, and you might be shocked to hear that there's actually good and bad. Let me start with the bad first. It's funded at 7.3% of GDP. So one of my cynical friends used to say that for every price there is a service. What I learned in the UK is that for some prices there is no service. And that is really a problem, that access becomes impossible within what some organizations within the UK are paid. If you have a rash and you want to see a dermatologist and your GP sends you to see a dermatologist, the average wait now is in excess of 18 weeks. Either the rash is gone or you're dead by then. It's really very straightforward. So, the hospital sector is massively inefficient. Length of stay in one of the hospitals we've been working on, the area where we've been, north of London, for the Medicare age population, averages 9.8 days compared to 4.9 days at Westmed. And their incidence of opportunistic infection follows along with that lengthy stay also. It is not only that they spend a lot of time, but they also spend a lot of time in a dangerous environment with other 5 patients in their ward, hopefully of the same sex. So the American public really is not going to accept what is funded by the NHS and the investment that they've made in what they call secondary care, which is specialty care, or in hospital care. It's rather interesting, by the way, parenthetically, that if you have a heart attack or you have a stroke, they actually have pretty good systems for getting you organized to the right place at the right time for the right care. And in areas that they've concentrated on, they've been excellent. And I would also say that for those of you who are not familiar with NICE, which is their review organization for approval of services, it's a remarkable model that the vast, vast majority of physicians agree makes the right decisions as to what services bring value and don't bring value, and allows for a national system of value. So that's the good and the bad of the general system. I'd like to spend my next 9 minutes on primary care and what's happening in primary care. So in 2004, there was a reform for primary care that went to fully capitated payments for a bundle of services, which are most of the primary care services. And in addition to that, there was QAF. QAF, as you heard, stands for the Quality Outcome Framework. And today it includes 556 points. There are over 100 parameters in QAF. The vast majority of them are process parameters, and I would actually rename it as QPF, where the P stands for process. Unfortunately, I can't figure out how to pronounce that. So we'll continue with QAF for the time being. And the average physician and GP who wants to survive in practice is currently getting about 90+% of their QAF points. Many are getting in excess of 95%, and it now is about 25% of their income. So the average GP in the UK is currently getting somewhere in the range of £90 on a capitated basis, which is carefully adjusted, by the way, on this formula, which is secret. So they'd have to shoot me if I disclosed it. But that determines the capitated payments based on the patient's age, demographics, whether the patient's institutionalized, like in a nursing home, et cetera, and what their socioeconomic status is. All goes into determining what your capitation level is. So that's your base capitation, and then you typically earn somewhere in the range of about £30 or £35 from your QAF points. What happened was when the government put this in 2004, they budgeted the average physician to accomplish somewhere in the range of 70 to 75% of QAF. Their budget was broken within 2 years as physicians basically did exactly what you expect them to do. If you pay them to do things, they do exactly what you pay them to do. And therefore, almost everybody was able to get their QAF over 90%, much to the surprise of everybody. So the single most important lesson in QAF, and QAF is exactly what you'd expect, right? You know, did you do the blood pressure? Is blood pressure controlled? Did you get hemoglobin A1C for diabetes? Give aspirin, you know, for someone who's had a heart? All the usual parameters that you would accept, and these have all been reviewed by NICE and by the British Medical Association, which negotiates on behalf of the GPs for their 5-year contract renewals. So that system has been in place, and the problem is that, and I'm sure most of you recognize the problem, this doesn't get you coordinated care. It gets you flu vaccines, it gets you, Pneumovax, it gets you a pap smear, and I'm not minimizing any of those things, all of which are extremely important, and I'd suggest that they have a much higher rate of the public health type interventions than we have here because they focused on these things, but what they don't have is coordinated care for sick patients. And that really is the biggest problem that they face, and they've also faced the problem of how to reform the hospital sector. So what you learned from the GP experience, and we call it the 3 I's, which is it's based on having the right information about the patients. Its second I is infrastructure. The GPs get forms. There are only 2 major EMR vendors in all the UK. Every year, those vendors come out with new QAF forms that are templates that match the QAF requirements. In their EMRs, they have their registries of who's in which category for QAF. Every time a patient is launched in the system, a pop-up comes and tells you what QAF is missing, and almost every GP practice has a QAF coordinator whose job it is to keep it going. So what they have is very good infrastructure. The government takes the QAF data out of the EMR every single night and de-identifies it. So their QAF is up to date every day, and the government up to every day. You know exactly how much money you're going to make in QAF every single day of the year. You know exactly where you need to go. So infrastructure, in addition to information, was extremely important. But the third I is incentives. And getting the right incentives. If you don't pay enough for behaviors, you don't get the incentive you want. So I think there's a lot to learn about the kind of information, infrastructure, and incentives that are necessary in order to accomplish these kind of quality initiatives, and be very careful about how you choose what metrics you want and how you're going to accomplish those. Lastly, what am I doing in the UK? So 2 things I'm doing. First of all, GPs are going out of business because the total payments to them is inadequate, and basically it's cheaper now, it's easier now to be a non-partner of a small practice and just go work for somebody. The whole concept that GP practices are owned by their partners is falling apart because of poor payments. And the other reason is because they're small businesses and they're not run at scale and they're not efficient. So we're in the process of building what we call GPMSO, which is an organization that will help the GPs run their practice at scale, improving their analytics and improving their performance. And it's been very well received, and we will launch the first of the year. The second thing I'm doing, which is actually more interesting, is we're beginning to look at how do you build ACOs in the UK. And there was enormous political movement to do this. And once again, the hospital acute sector has come up with a million reasons why it can't function that way. But the country is now divided into 44 STPs, and those are being divided into health areas. So the STPs have about 1 million people, the health, and with some governance over the payer mechanism. Those are being broken down into health economies, which average about 250 to 300,000 people, which will be the primary delivery units for ACOs. And the physicians are being encouraged to aggregate, the primary care physicians, into the equivalent of medical homes that will have 15 to 25 GPs per unit, and they'll care for between 30 and 50,000 in population. And actually, if you think about that from a capitated standpoint, that is a very, very efficient organization. And people expect that over the next 5 to 10 years, the dominant mechanism of payment is going to be into these middle-sized units, and the predominant GPs, QAF will go away and be replaced with local mechanisms for payment of quality within these individual health economies. So I'll stop at that, and I'll take any additional questions if there are some.
So I'm going to try to leave time for the audience. I am sensitive to the time, but I want to come back and ask Antoine one question. So I noticed from your slides that it looks like there's a lot of variation across the provinces in who relies on the on the alternative payment models. And I wanted to get a sense from you if you can say what the conditions are that in some provinces relative to others that are leading to greater reliance on the alternative payment models.
It's a good one. Difficult to say that there's one province leading. We kind of have 10 very, very tiny United States of America innovating very actively, but not spreading what their innovations are across the country. We're not doing so much transformational knowledge transfer, and this is certainly an issue we're facing. So it's difficult to say that, for instance, Ontario or Quebec is a leader. For sure, different innovations like the ones we're doing in Quebec with valorization of certain patients, more vulnerable patients, and giving bigger bundles for taking care in terms of capitation of these patients is an innovation. Another one is the one I presented with this access rate. This is also very inspiring for Alberta and Ontario, and we ourselves inspired ourselves with initiatives made in Alberta and Ontario. So it's kind of a blend of different leadership sectors in different provinces, but I could hardly say that we really have one very specific leader somewhere. So these differences really are showing the diversity and the unique character of every single health system. We really have a very unlike France, for instance, that really have this broad system, this broad and general system for the whole country. We do not have that in Canada. It really is separate.
You know, I guess I was asking because I was wondering problems provinces than another. That seems to be more of the motive.
On the other hand, can I just, I mean, in another sense, Canada is more, France is more pluralistic, I would say, than Canada. In some senses, France is more pluralistic than Canada. There are private for-profit hospitals. 1/4 of hospitals are private for-profit. Nothing like that in Quebec. The others are public. You have fee-for-service. You have health centers. You have a whole, very pluralistic set of arrangements, which are far less, in fact, centralized. But with the fee schedule, that's centralized. But that's centralized in Quebec too, isn't it? Just
In Quebec.
In Quebec.
Yeah. Before.
but not in the other
Not
provinces.
across the other provinces. There's no. In other words, there's no national payment schedule. There's no,
No, that I
Canadian fee
understand.
schedule.
No, that
Yeah.
no, that I understand. I was just thinking about across the provinces.
You know, I would add one interesting thing, by the way. One of the reasons that costs are low in the UK is because their unit costs are low. And one of the problems in the US, particularly outside of Medicare and Medicaid, is that unit costs are ridiculous, right? So, you know, one thing you can learn from some of these countries is that they have national systems for unit costs. So even if you don't want Medicare for all, maybe you just have the Medicare fee for all.
That's certainly an idea that has been talked about. So, yes, it's called all-payer rate setting. That has been considered. So I'm going to ask just two very short questions. One for Victor. So Sector 2 is kind of very interesting to me. I know it's kind of settled law in the United States that Medicare is not going to allow balanced billing, but it sounds like balanced billing is allowed in France. So has that
tact and measure.
Yeah, with tact and measure. So with tact and measure, has that created any access problems? Are certain populations feeling that they're excluded from certain providers who, you know, maybe are not quite as tactful and measured as they might be to certain populations?
No, it's a big problem. I mean, everything is relative. It's a big problem within the hexagon. It's not a big problem when you compare it to the United States. Within France, it's a major problem, and many steps have been taken to deal with the problem. For example, in this latest agreement from 2016, those physicians in Sector 2 are given higher rate increases if they will take care of certain categories of patients who are equivalent to our Medicaid patients, I mean, to the extent that 1 or 2%. So the magnitude of the problem is much smaller. But so measures have been taken in this way, and also to promote access in areas with underserved physicians. Also, there have been limits placed on how much extra you can charge. When tact and measure didn't work, there were some guidelines about not more than 2 times, maximum 3 times the assigned fees.
You know, that's a lot more room than Medicare has. And in terms of, you know, not getting coordinated care from the QAF, but is there evidence that there's improved health outcomes? Is the population getting healthier?
Unfortunately, in the UK right now, the population is following the same trend in the United States, which really is a crisis. The non-college educated working class, middle age is dying faster. So very, very similar to the same health data in the United States, a combination of alcohol and substance abuse and some other traumatic events. So the global health policy issues in the UK now, because of that. So yes, if you make it to 75 in the UK, you're probably okay. But if you're between 40 and 55, and you're a white male who is not well educated and was in one of the Rust Belt industries, you're in trouble. So that's become a big focus of their healthcare policy. But in terms of really, is the population healthy as a result of that? There's really no great evidence for that.
Questions from the audience? Katie, and then...
I don't need a microphone.
She doesn't need a microphone. I know her.
They make me use it anyway. So, Simeon, as someone who's spent a bunch of time in the UK off and on over the last 20 years, one of the things that impresses me, and this is among people my age and older and somewhat younger, well-educated, high-achieving, an incredibly strong devotion to the NHS and an incredible pride in the NHS. And I literally think it goes back to, like, the war, and, like, it's what came out of the ashes of, like, a horrible period of their history. And even rich people who can afford better stay in it. And I feel like that has a lot to do with something about what it can and can't do. And I don't know if A, if I'm overstating it, and B, if you think that informs what the toolkit looks like, just the national commitment to the enterprise.
And that's absolutely true, by the way. The public historically has loved the NHS. They don't care that there's 6-bed wards. They don't care they wait 18 weeks. The government's going to take care of me, and I pay nothing. And by the way, it's first dollar coverage. There's no copays. There's no nothing. Patients love that. Big success. The problem is that the millennial generation that is now coming up does not have the same love for the NHS. 20% of the population already has private insurance. that wasn't present before. And the third problem really is that their total scores are now going down for the first time, and there's enormous pressure on the government to fix the system, which they see in crisis. And actually, right now, just before I left London, there was a comment, and I remember by which member of Parliament, but that the number one health issue now, the number one political issue in the UK is not Brexit, it's the NHS. So it gives you some idea for their sense of crisis at the moment.
Thank you very much. We hear a lot in the States about the expense of going to medical school through being an intern, through being a resident, and how that impacts on the type of doctors that result. Less primary care doctors, more whatever. I wondered if each of you could talk about the mechanisms in place for generating doctors and how they're working.
Like it?
Yeah, as quite said, in the UK, by the way, all physicians are paid very similar amounts of money. So there's not a huge economic incentive. In fact, actually, if you're an entrepreneurial physician, you can make your most money being a GP. The problem is that no one wants to be a GP for two reasons. Number one, the rest of the medical profession looks down on you, and there is really a bad culture about that. And the second problem with being a GP is that the daily work is unbelievably challenging and stressful. The specialists sit in hospitals, have a lot of opportunities for coffee, early time to the bar in the evening. It's a much better lifestyle. The pub, I'm sorry.
There's not the problem in France of debt for medical education that you have in the United States, so that doesn't play in at all. But since the fee schedule is so similar to our fee schedule, if you want to make money, you go into the specialty services, the most highly paid categories. And the fee schedule, as the French see it, is not just about science and the proper value of the fee. It's about incomes policy and what you get paid as a physician across specialties. So it is well known. Radiologists, 6-7 years ago, were the most highly paid profession. And eventually, through the negotiations and through some state intervention as well, those fees were brought down for the radiologists. Now the anesthesiologists are the highest paid profession, and measures will be taken probably by the government because they don't work out in negotiations to lower those fees as well. So the incentives are there still to go into the specialty services in France, but you have over 50% still as GPs, so it's not as severe as in the United States, although it depends how you define primary and specialty care in the U.S.
In Canada, medical studies are very cheap, as you might know. If you're Canadians and go to a med school, it's whatever med school you choose, it's almost all the same, and more or less $5,000 a year for the number of years you're studying medicine. So it's not, the issue is not there. Afterwards, we get much closer to the UK, where we have, it's not a matter of having differences, well, they don't. We do have huge differences between GPs and other specialists. We really are, there's a gap. It's almost twice as, the earnings are twice as, or twice bigger for other specialists than for family doctors. And definitely the interest for family medicine in Quebec and Canada at large really is lower because of that gap, mostly because at some point, if you hesitate between cardiology and family medicine, you say, okay, I like both. This one is going to bring me $500,000 a year, the other one $250,000 a year. Well, who's stupid enough and say, okay, I'll go with the quarter. So it's kind of an issue that's not really happening, but this is what happens behind that. Nevertheless, we do have issues of interesting family doctors into family medicine nowadays, but mostly because of this issue, and not because of this historical relation between family physician and other specialists that looked a little bit like what's happening in the UK, but but it's not happening anymore. We don't hear so much in younger doctors. We can hear it in older doctors, but in younger doctors, they do recognize this load that family doctors are taking on their shoulders, and they do recognize this quality of life thing that is definitely more difficult for family doctors than other specialists. So these are the issues, I'd say, because they're Canada.
Okay, and one last question from Eric.
Great, thank you. This should be brief. To Simeon about the UK, two things. One, the mortality amenable to healthcare in the UK between 2004 and 2014 dropped faster than 11 countries, high-income countries.
I'm sorry, I didn't, one more time, please.
The mortality amenable to healthcare in the UK dropped more than 10 other countries in high-income class between 2004 and 2014. So I think there's some evidence that they've made gains. The second observation is that they've been shrinking their national health spending budget year over year, which is unimaginable, I think, in most other countries. And I'd like you to comment on that context. And then the third is coming back to our theme of today. As they move to ACOs and other kind of management-intensive approaches to delivering health care, are they considering creating service code, fee schedule, like resource management systems, and what will those be based on?
I didn't know that data. Thank you for that data. Second of all, I'm not aware of any interest in creating remember, all the hospitals and specialist care are already on fee-for-service, right? They're already paid, and needless to say, there's no shortage of services provided. But my understanding was that they were up over 9% of GDP. So they've contracted about 25% in the time when the economy has grown, but as you know, nowhere near the pace that they would have liked. And the interesting thing is that when the Labor Party ran on various NHS reforms, none of it was proposing a higher percent of GDP to be spent on healthcare. So I think that the emphasis is really on moving to more efficient systems, because the unit costs are very low. So if you think about that, if your unit costs are low and you don't think there's no evidence that they provide more services than we do, right? So if your unit costs are low and your service volume is contained either by rationing or by access or whatever else you want to do, then the only thing you can really do to improve your system is improve your efficiency and your coordination of care.
Okay, please join me in thanking these panelists who did a great job on very short notice.